My name is Daniel Southern. I am the medical director of Interventional Orthopedics CT. And tonight we're going to introduce you to a new field of medicine, which really represents a new field of medicine in orthopedics and offers alternatives to orthopedic surgery. I'm going to introduce the basic tenets of the field. I'm going to discuss how it works, where it fits in the algorithm of orthopedic treatment, discuss some of the science behind it. I'm going to go very light on the evidence because that kind of gets deep into the weeds. I'm going to show you a few examples of what this treatment is. And then we're going to discuss two case studies. Now, they happen to both be feet tonight, but they could be knees, hips, they could be necks or backs, they could be shoulders or elbows or wrists. I treat virtually every joint in the body. Tonight, we're going to discuss two case presentations. They both happen to be feet. They have kind of dramatic before and after, so I like to brag about them a bit. Let's begin by just talking briefly about my journey into medicine. I began my life as a professional dancer, as a matter of fact, and I had back pain for various reasons. Happened to be quite tall. I got a lot of real estate to control. I did miss the pit coming down from 13 feet in the air as a pole vaulter in high school. That might have had something to do with it. At any rate, I developed back pain, and I'm a young man in New York City dancing for a living, and I pony up $250. And this has got to be the early 80s. So that was a lot of money. And I remember distinctly how much it was to go and see an orthopedic surgeon. And this doc was a helpful guy. He tried his best. He did an examination, he took an x-ray, he pulled out a spine model and said, well, it could be a disc, it could be a joint in your back, and then the muscles are all part of that. And I said, well, doc, what do I do about it? Because it's really beginning to, limit me. And he said, well, this is what we're going to do. I'm going to prescribe a barbiturate for pain, which I want you to take when you have a pain that you can't handle. And I'm going to give you a back brace, and I want you to wear that all the time. And oh yeah, the dancing, you got to stop that. And the minute he said that, I knew that I had wasted $250. Needless to say, I did not stop dancing. I continued to dance, and I learned a lot about how to deal with my pain. I discovered reflexology, number one. I found a chiropractor, an old Palmer guy who did hole-in-one that I found very helpful. And most importantly, I learned the benefits of stretching the largest muscle in your body, which is your hip flexor. So that fast forward a decade or more later, when I applied to medical school, I knew a lot about back pain. And one thing I knew about medicine was that even a highly trained, highly skilled orthopedic surgeon did not have all the answers. So I get through medical school and I come out and fast forward, suddenly I'm the orthopedic guy. I'm working in a large orthopedic practice. I'm seeing 35 to 45 patients a day. And I am injecting patients in all their joints with steroids, steroids, steroids. I am burning out nerves in the knee for pain. I'm burning out nerves in the neck and back for pain. I'm placing spinal neuromodulators. Why am I doing all this? Because this is all that insurance pays for. And it's not working out very well. My patients are not getting better. And just about at the point where I feel that I got to find something else to do for my patients, my secretary comes back from leave, having delivered her first child, and she's got an intractable carpal tunnel syndrome in her wrist. And I injected it with steroids. And she was great for about a week. And I said, well, I've been doing some reading. Why don't we draw some of your blood, capture the platelets, and I'll inject the carpal tunnel with platelets. And, it can't be any worse or any briefer than a week's worth of release from steroids. And so we did. And it went away and stayed away. And that was my first success. Another employee in the office had intractable neck pain on the right side behind her ear. And we got an MRI, and sure enough, she had a C2-3 facet joint in her neck that was arthritic as all get out. And I injected it with steroids, and she was better for about 2 weeks. And based on my success with the platelets, I said, hey, let's do platelet-rich plasma injection into that. Let's draw some of your blood and I'll inject some of your platelets. We did, and I hit another home run. It never came back. She was thrilled, and so was I. And really, for more than a decade now, this is all I've done. I have not looked back. So what is it exactly that I'm doing? Well, what I'm doing is a new field of medicine. Let me share the screen, and we'll begin with the presentation. Interventional orthopedics is what I'm doing. What is that? And how does that compare to traditional orthopedics? Well, let's compare them. What is interventional orthopedics? Traditional orthopedics is basically using scalpels, drills, and saws, a lot of tools to place a lot of hardware, which includes screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is one of carpentry. Compare that to interventional or regenerative orthopedics. We are using only needles and very advanced imaging, which includes fluoroscopy, which is real-time X-ray and ultrasound, to inject. What are we injecting? We're injecting our patient's own blood and or repair cells. We're delivering growth factors to damaged tissues, trying to stimulate them to repair themselves. The metaphor here is one of gardening. In traditional orthopedics, we are removing and rearranging tissues. We are deconstructing and reconstructing. We are replacing native structures. In interventional orthopedics, we are attempting to stimulate the repair and regrowth of tissue. We are preserving native structures. Now, this distinction I can't emphasize enough. Why? Because the design of the human body has been refined over many thousands of years, quite literally. And anything you do to alter that design, whatever it may give you, it comes at a cost. What am I talking about? The importance of preserving native tissue can be illustrated by an operation that orthopedics are extremely proud of: anterior cruciate ligament repair in the knee. This is a procedure that gets athletes, professional athletes, back on the field of play. Unfortunately, it doesn't get them back for very long, but it does get them back on the field of play. The first thing you need to know about ACL repair is that it's not a repair. The traditional ACL repair is taking out, and that's illustrated right here, by the way. This is the femur bone, this is the tibia bone. That's a screw, this is a screw, and that dark thing is a ligament. But it's not the native ligament. This is a cadaveric ligament from a dead man, or this is a ligament harvested from another part of the patient's body. They don't repair the ligament when it's torn. They cut it out and throw it away. They use these screws to place a replacement ligament. The problem with this is that the angle of this repair does not quite duplicate the shallower angle of the native ligament, because they can't do that, because they've got to drill behind the femur bone and in front of the tibia bone to anchor this darn thing. And because the angle of the native ligament cannot be reproduced, we think that causes a rotational instability, because this procedure does solve the front-back instability of the femur on the tibia. But we think it creates a rotational instability which destroys the knee. And it is now well known that with the traditional ACL repair, typically within about a decade, the knee is shot. It's totally arthritic and it needs replacement. This is an article in the New York Times published in 2017 discussing this very fact from the perspective of the teenage athlete. And we're talking 15 and 16-year-olds now. The article mentioned that ACL repair rates in adolescence was soaring. There had been a 5-time increase from 2004 through 2017, following 26 different hospitals across the country. A Dr. Coker from Brigham and Women's in Boston was quoted as saying that 50% of these 15 and 16-year-old athletes will develop knee arthritis within 10 years of the tear. Imagine that. You're 15 and 16, you tear your ACL, you have a traditional ACL repair, and if you're one of the unlucky 50%, you get to be 25 or 26 and the knee is shot. And you go to the orthopedic and he says, well, we got to replace it, but we can't do it now. You got to deal with it for another 20 years before we replace it sometime in your mid 40s. So the article ended with the question, will surgical techniques that more closely resemble native anatomy reduce the risk? And the answer to that is a resounding yes. If you can preserve that ligament rather than cutting it out and replacing it with a graft, that knee is going to survive, has a better chance of surviving. Let's talk about the traditional algorithm in orthopedics today. The traditional algorithm starts with an injury, of course, and say you bang yourself badly and you go home and everybody knows what to do. You rest it, you wrap it, you put ice on it, you take a couple ibuprofen, and most of us get better in a day or two. Things improve, we hobble around, we get back to the field of play. But if it does not, you go to your primary care doc and he says, well, go to physical therapy. And he writes a prescription and you go to physical therapy. And usually that, working with a professional rehabilitationist, will solve the problem. But when it doesn't, you go back to the private medical doc. He says, well, go see my friend, the orthopedic. And you walk into my office and I go, hey, let's inject it with steroids. So we inject it with steroids and that can make it feel a lot better, but usually for a short period of time. And when it wears off and you come back, the orthopedic now says, well, let's get an MRI. Well, if you're standing in an orthopedic surgeon's office and you're looking at an MRI of yours, your chance of having a surgery go up about 90%. And one thing about surgery is it tends to lead to more surgery. And over time, surgery, time passing, age, the only thing left is total joint replacement. Now, in the spine, this would be spinal fusion. Okay, so this is the traditional algorithm today in orthopedic medicine. What's wrong with the algorithm? Well, there's lots of things wrong. Let's start with steroids. Steroids are terrible. You shouldn't be injected into joints. Why is that? Because steroids are toxic. They kill every cell they come in contact with. And when you inject them into a knee, what they will do is kill chondrocytes alive in cartilage. They will kill tenocytes alive in tendons, fibrocytes alive in ligaments, and osteocytes alive in bone. They're very, very destructive. This is a study. It's a rather famous study from the Journal of the American Medical Association in 2017, where they randomized knees to injections with steroid, triamcinolone acetate, 40 milligrams, every 3 months for 2 years, compared to the opposite knee, which was injected with normal saline every 3 months for 2 years. In other words, sterile water. They got MRIs before they did this and MRIs 2 years at the end of the study. And what do you think they found? In the knees that had steroid injections every 3 months for 2 years, there was a 50% loss of cartilage. Why? Because steroids had killed chondrocytes and that cartilage had just worn away. When this was reviewed in the orthopedic practice I was involved in for years, my comment was injecting steroids into knees should be considered malpractice based on this study. And this is a level 1A evidence, okay? It was a randomized clinical trial. This was no prospective study. This was the highest evidence we have in medicine. We inject steroids into knees along with bupivacaine and lidocaine. These are common local anesthetics. These substances are even more deadly to cells than steroids. So the whole idea of this is just not good because over time, all it's doing is pushing you towards joint replacement. Now, if you walk into my office and don't know what I do, and I think a steroid injection is called for and you've never had one, we'll do one. I'll do one. I will not do another. And I'll explain to the patient why. Everybody's entitled to one because every orthopedic office in this country will inject steroids as a first step in the treatment of joint pain. So it can be done once, but I would never do it again because it ruins the knee. What's wrong with the current algorithm? Meniscectomy. This is also known as the let's clean up the arthritis surgery. This is a surgery that should not be done. The evidence is quite clear on it. What this is a meniscectomy. The meniscus are large hunks of cartilage within the knee, on the inside of the knee and on the outside of the knee. And when there is a tear seen on MRI, this is not a meniscal repair. Again, this is cutting out the meniscus until the tear can't be seen anymore. And when you do that, what you do is you increase loading forces in the knee. And whatever you get in terms of reduction in pain briefly over time, what you've done is you've destroyed the knee. Why? Because good studies, repeated studies, have shown that after meniscectomy, patients have a 3 times increased risk of arthritis 8 years after that surgery. So it just accelerates degenerative processes. The only reason it should be done, there's only one indication. If the meniscus is torn so badly that it kicks up a flap of cartilage that gets mechanically stuck between the bones as you're flexing and extending the knee, then we have to go in and cut that meniscus out. We have to. But short of that, if your knee is not locking, and that's the term for that, then this surgery should not be done. Is it still done? You bet it's done every day of the week across the country. What's wrong with the current algorithm? Joint replacement. Joint replacement is just not what it's cracked up to be. In the knee, specifically in the knee. The literature indicates that approaching 50% of patients who have a knee replacement have the same or worse pain than they had before the replacement was done. Very few of them get back to normal functioning. Only 1 in 20, 5% achieve normal activity levels after this procedure. Many patients complain of continued pain, as I just mentioned. As much as approaching 50% of them have the same or worse pain after this procedure is done. And then over time, there's a risk of metal and material fragmentation causing granulomatous inflammation and typically the ultimate need for a revision, a replacement of the replacement that you've had. So, what is the promise of interventional orthopedics? Well, first of all, the promise is that you avoid surgery. The promise is that what we're doing is using the body's ability to heal itself. We're harvesting repair hormones, we're concentrating them, and we're focusing them at the site of injury. And that's key, and that's the art of what I do, is getting it into the precise tissue. This is a lot more than just taking platelets or stem cells and throwing it into a hip or a shoulder joint and saying, there, you've had a stem cell procedure. The stem cells will find their way to the areas of damage and they will heal it. That's not how it works. That's not how it works. You got a tear in the labrum, cells have to go in the labrum. You have a torn inferior glenohumeral ligament, cells have to go right into that ligament. So you have to have the skills to do this, okay? Number 2, it's minimally invasive. This means that it's a fraction, literally a fraction of the risk of surgery. It is a fraction of the recovery time of surgery. It's a less painful rehabilitation following these procedures. And the final result is preserving native structures. There is no need to alter or to replace the native structure. And that's huge, as we've just discussed. So how are we doing this? Well, the term for what I'm doing is the use of orthobiologics. And that is a term that comes from the use of a patient's biological tissue, their human repair cells, biological cells, to treat orthopedic conditions, hence the term orthobiologics. All right, where do we find these repair cells? These repair cells come from our patients. They are autologous, meaning that's a fancy word for self. We get them from our patients. And all I'm doing as a doc is I'm simply manipulating them, concentrating them, and then injecting them into the areas of damage to treat musculoskeletal injury. It sounds simple. It takes a lot of training to do this. Human repair cells come in 2 flavors. One is a small circulating blood cell known as a platelet. And so if you've heard of platelet-rich plasma, and lots of people have these days, what we're talking about is injecting one form of a human repair cell by doing that. The other is a more powerful repair cell, and that's an adult human stem cell. And in my world, stem cells come from the bone marrow. Why? Because stem cells from bone marrow, the literature has repeatedly shown, have a particular propensity to become the tissues of interest in orthopedics: cartilage, ligaments, tendons, and bone. This is why when we're talking stem cells in my world, we're talking bone marrow. Bone marrow aspirate, concentrated. Here's a little schematic of the balancing act in any joint in the body between forces that degrade the joint and forces that repair the joint. Again, we've got some fancy terms here. Catabolic forces are forces that break down a joint. Catabolism means to break down. And then there are pro-inflammatory forces. Pro-inflammatory forces, and we're talking here specifically about chronic inflammatory forces. These will destroy joints. Repair forces are anabolic. Anabolic means to build up. These are factors that build up and repair tissues in human joints. And then there are forces that work against breakdown, anti-catabolic forces. So in a healthy joint, these forces of breakdown and build up and repair are in balance, and there are no symptoms in the joint, and the joint works fine. But when you come into my office and you're complaining of, say, shoulder pain, and we've sent you to rehab and you haven't responded, and I get the MRI and see that you have a small tear in your rotator cuff, I say, well, I can probably fix that with platelets. So I'll recommend a PRP injection. Well, what exactly are we getting when we do a PRP injection? Well, we're getting a whole host of anti-breakdown forces, and these things are known as alpha-2 macroglobulin, IRAP, which is angiotensin receptor antagonist protein. TGF is tumor growth factor beta. TIMP stands for tissue inhibitor of metalloproteinases. All of these are various forms of protease inhibitors. Proteases are small enzymes that digest your cartilage. And in an arthritic joint, that's occurring. This is a very bad chemical microenvironment. All human serum has these master enzyme inhibitors. And the minute we inject them, we change very rapidly the chemical microenvironment inside that knee from a destructive environment to a pro-growth, pro-health environment. And this is usually the first peak of improvement which we see. And quite often, it can occur in a few days after we do a PRP injection. But that's not what we're after. What we're after is a long-term repair or regrowth of tissues. And we get that from platelets through powerful growth hormones, one of which is known as platelet-derived growth factor. Between the two of these things, we can repair small tears in tendons, small tears in ligaments, early forms of osteoarthritis in any joint in the body. Okay, let's say that you come in and the rotator cuff is actually torn. It's torn, but it's not retracted more than a centimeter. I'm saying to myself, I can fix that, but we're going to need stem cells for that. So in my world, again, what we're talking about is BMAC, bone marrow aspirated, concentrated. This is where we're applying stem cells. What do we get when we do a stem cell procedure? We get a whole host of powerful, very powerful growth hormones. And what we're doing by injecting PRP and or stem cells is we're putting our finger on the scale here. And what we're doing is we're tipping the balance back in favor of repair. Quite simply. So this was a talk that I gave to some local therapists in my community recently. And this was basically to let them know that everything I do cannot be done without their help, specifically physical therapists. I rely on my peers in medicine to help me improve the range of motion in a joint before we get to doing stem cells in that joint. I rely on them to help with your posture, with the alignment of that joint. And they may, I may prescribe orthotics, they may prescribe orthotics, I may prescribe a brace that can help with alignment and optimizing alignment. And most importantly, what we want to do is increase stability. Stability is a bugaboo. Any joint that is not stable is a joint that is going down. And joints, just in general, as we age, get less and less stable. So stability is a huge, huge issue. Now, I send you to physical therapy to work on the dynamic stabilizers of any joint, and those are your muscles, and that's where physical therapy comes in. Therapeutic exercise is aimed at strengthening dynamic stabilizers of your painful joint, and that's often how it works. We get your muscles a little stronger, and that knee pain, that hip pain, that shoulder pain goes away. The other form of stabilization are the static stabilizers. These are ligaments. And as we age, or if you've been an athlete and you've injured a ligament, it's very difficult for a ligament to repair itself on its own. Why? Because it has a very poor blood supply. And even when you tear it, there's not much blood in the area. And because there's not much blood, the tissue doesn't see many of these repair cells. That's where I come in. I come in with the repair cells concentrated and then I inject them right into the ligament. So as we age, even if you've never had an injury in a ligament, ligaments get lax. They get stretched out and they contribute to instability. Unfortunately, physical therapy can't help that because ligaments attach bone to bone. There's no muscle involved. So you can get as strong as you like. Your ligaments are still going to be loose and sloppy. How do I treat those? I treat those with an injection technique known as prolotherapy. And this is a injection technique that I rely heavily on, and this whole field relies very heavily on. It's the direct injection under direct visualization of tendons and ligaments and other connective tissues to make them stronger. So what is prolotherapy? Prolotherapy can be defined as a growth factor stimulating injection. The body repairs itself through an inflammatory cascade. And when we inject pro-inflammatory substances, things that are irritants, irritating, it causes inflammation and it stimulates a repair process. What we're doing with prolotherapy is we're trying to address connective tissue insufficiency. And we do that by triggering inflammation. And this is distinct inflammation. This is acute inflammation. This is the inflammation that causes the swelling and the redness after you bang yourself or hurt yourself on the field of play. That's good inflammation. You don't want to mess with that. You don't want to rush right to ibuprofen. That's a bad idea because you're interfering with an inflammatory cascade, which is a repair cascade. So in prolotherapy, what we're injecting is an irritant solution to set off an inflammatory repair process. It has to be done repeatedly. This injection technique has been around about 80 years. We have not always used repair cells doing this injection technique. We've used irritant solutions. What are they? Well, they're 12.5% dextrose. That's sugar water. Sugar water is very irritating, and sugar water is easy to make. You just take some dextrose and dissolve it in water. And if you inject it repeatedly into a ligament or a tendon that is torn, it will repair itself over time. And this is not magic beans. Good bench work, scientific bench work has shown that ligaments get thickened and it enlarges the tendon osseous junction. In other words, where the tendon or the ligament interdigitates with bone, that tendon osseous junction, it gets larger. So it makes that attachment from bone to bone of a ligament stronger. It makes the attachment, the insertion of a tendon, a muscle tendon into bone much stronger. The difference with what we're doing in interventional orthopedics is that we're no longer just injecting 12.5% dextrose. We can, but it takes a lot more treatment to get the same effect. Now what we're doing is we're injecting human repair cells, platelets and or bone marrow. Remember, bone marrow means stem cells. These are precise injections. Again, as I said earlier, you have to hit the damaged tissue. You can't just throw them into a joint and say, yeah, there they go. You can get an effect doing that. Yes, you can. But to get the best effect, you need to inject the damaged tissue specifically. That means you have to see it, and you have to learn how to see it under ultrasound and the use of real-time X-ray. What we're doing is we're stimulating an inflammatory repair process, and repeating prolotherapy only makes these ligaments and tendons stronger. This is a prolotherapy schematic of shoulder injection of the rotator cuff. This is the rotator cuff coming over in the shoulder and inserting onto the humerus of the upper arm. And these are, of course, hypodermic needles showing the injections of repair cells into these. This is the middle glenohumeral ligament. This is the supraspinatus and the infraspinatus. These are some of the rotator cuff tendons. Let's go back to the treatment algorithm and see how we have changed the traditional algorithm by the use of orthobiologics. If you're standing in my office and we're looking at an MRI, chances are very good. In fact, they probably go up 90% that I say, hey, I think I could fix that with an orthobiologic injection, either your platelets or your stem cells. If you agree to that, when we do it, I'm going to send you back to physical therapy. And when that process works, what we have done is we've taken you out of the algorithm and we have preserved your native tissue or your joint. And we've taken you out of the algorithm that is pushing you towards joint replacement. We've taken you right out. We've taken a left turn right out of that algorithm. That's the beauty part of what I do. Here's some examples of interventional orthopedics. This is a setup in the procedure suite. This funny looking thing is a horizontal C-arm. This is the camera. This is the image intensifier. What's heavily draped here on the surgical table is a knee. And this is the X-ray, the real-time fluoroscopic view of that knee. And if you look closely here, you can see that there is, in fact, a trocar that I have embedded into the kneecap or the patella. And there is a smaller, very thin needle that's being put right behind the kneecap. And this is why we're doing all this. This is an image from the MRI of this knee and of the same slice that we're looking at on the fluoroscope. This is the kneecap, and this is the distal thigh bone known as the femur. The gray stuff behind the kneecap is the cartilage, and if you look closely enough, you can see that it's breaking up. This is called chondromalacia, and this is why the needle is injecting this dye behind the kneecap. The dye just shows me where the stem cells will flow when I inject the stem cells. This bright starry thing inside the kneecap is why we have drilled into the kneecap and are injecting stem cells there, because this is a bone lesion. This will become a pocket of dead bone if it's not addressed. That's why we have drilled into the kneecap to do this. But this shows the elaborate nature of what we do in interventional orthopedics. And it's all done with needles. No one is using a scalpel or placing sutures or cutting. That's not happening. These are all needles. This is fancy needlework. This is the injection of a shoulder. This is two placements of a needle in sort of real-time fluoroscopy. The first placement of the needle is into what we call the glenohumeral joint. And that's this semicircular, thin, elegant line right here. This is dye that I am injecting before I inject the cells. The second placement is into this triangular area right here. That is the labrum. This shows the precision that is required. If you want to address the cartilage of the glenohumeral joint, you have to inject the glenohumeral joint. If you want to inject the superior labrum of that joint, you got to put the needle into the labrum. Here's another example. This is a hydrodissection of the median nerve at the wrist under ultrasound. You'll see the needle coming in from the left. This is the median nerve. What we're doing is very delicately and carefully injecting around it. You see the needle coming in, the injections occurring. For scale, this is the size of a green pea. It shows you how delicate this work can be. We do this for carpal tunnel. This is what I did on one of my employees years ago that I explained earlier. Okay, we're about to finish. I have two quick case reports I would like to show you. The first one is of a 20-year-old soccer player. He was pushed from behind. He landed hard on his right heel, and it hurt. He was able to finish the game, but he was limping after he finished. Several days later, something very similar happened. He re-injured it, and the pain was so bad that he had to stop playing. And when he showed up in my office, he was terrified. He was a, 18-year-old. He'd gotten a full ride to a Division I school to play soccer, and here he was. He couldn't play. He had 7 out of 10 intensity, heel pain. Just standing on it was painful. He couldn't push off on the right foot. He couldn't run. He couldn't jump. In other words, he couldn't play soccer. This rocked this kid's world. I did a quick exam. He was a healthy specimen of a kid, 6'1", 175 pounds, walking with a bad limp. He had full ankle range of motion. He had no edema or swelling. He had tenderness over the bottom of his foot, about right here. His neurologic exam checked out. There was no problems with his knee or his hip or his back. We took x-rays, and of course the x-rays were perfectly normal because there was no fracture. It's a perfectly normal looking ankle and foot here. Nothing wrong with it at all. We ordered the MRI, and if you look closely, you can see the green arrow sign. This is a side view of the foot and ankle. This is the heel bone. This dark thing here is the plantar fascia. This is the fascia that connects the heel bone to the base of the metatarsals, which are your toes. And it holds the foot together. And this is where you get spring when you push off with the foot. And if you follow this black line back, you will see, if you look closely, that it stops right there and it misses the bone. If you keep coming over, you can see remnants of it inserting into the bone, but it's just remnants and they're flapping in the breeze. He has a complete tear of his lateral plantar fascia. This is another view of it. This is looking up at the bottom of the foot. This is the medial plantar fascia. You see it come down and insert into this gray thing, which is the heel bone. This is the lateral plantar fascia. It comes down and it stops short of the bone. This is a view on MRI of the back of the heel. You can see the medial band of the plantar fascia fully secured, securely attached to the bone of the heel. Here is the retracted lateral band not attached to the bone. He had a complete tear. This was a bone marrow case all the way. So I drew some of his bone marrow, concentrated it, injected into the plantar fascia, put him in a boot, started cross-training about 4 weeks after the procedure, just to maintain cardiovascular conditioning. He was swimming, working out on a stationary bike, doing Pilates. At 4 weeks, we started to gently stretch the fascia. At 8 weeks, we began to do some more dynamic stuff out of the boot. The plan was to get an MRI follow-up at 12 weeks after the treatment. He was so desperate to play in his first, fall season in college that he ran out and got it at 11 weeks, and this is what we saw. Here it is, coming back, coming back. Now, the darkness changes to a slightly less dark tendon, fascia rather, but you can see that it comes over and inserts into the bone. This was a hallelujah moment. This is the view of that 11-week MRI from the back. You can see the lateral plantar fascia has regrown and implanted back into the bone. This is the before view where it's off the bone, and this is after at 11 weeks after bone marrow stem cell injection implanted back into the bone. This is before. Follow the plantar fascia back, it doesn't attach, and this is at 11 weeks. Comes back and attaches into the bone. The patient was pressing to play his last game of his first collegiate season. I said to him, don't do that. It has reattached to the bone, but it is not mature. A healthy athlete like you're out on the field to play 5 minutes in a competitive match, you're going to rip it off the bone again. Don't do that. And he didn't. We helped him obtain redshirt status for the season. And now he didn't go on to play professionally, but he did finish his 4 years in school, and he was thrilled with it. And I was too. It was a great case. This is a very similar case, another plantar fascia. 48-year-old dancer, prima ballerina, injured landing on the right foot, continued to dance. Injury progressed, pain got worse and worse. She couldn't push off. She couldn't land her jumps without pain. She went to a very well-known podiatrist who takes care of ballerinas in New York, and he got this image under ultrasound. This is the plantar fascia. This is more normal-looking fascia here. This is this really amorphous major tear in the plantar fascia of the central band of the plantar fascia. And basically he said to her, yeah, that's a bad tear. It's going to take about a year to get better. She came into my office limping about 8 months after that and still not able to dance full out and was in great pain. And this is the ultrasound image I got. Pretty much the same, wildly thickened, sort of amorphous plantar fascia here off of the bone, which is this hard white line. And this is the image that I just showed you that was taken at the time of injury. Pretty much the same looking, very gnarly, badly torn plantar fascia. We did bone marrow in her as well. Numbed her up, injected. Here's the needle coming in. This is the hard signal of the heel bone, and this is the plantar fascia that I'm injecting with the needle. We put her again in a boot. We started cross-training just to maintain cardiovascular conditioning. At about 12 weeks, she went back to doing bar work and started rehearsals at about 75% speed at 20 weeks afterwards. She came in for a follow-up. And this is the ultrasound image of the right plantar fascia that we had injected and gotten to repair. This is her normal left foot plantar fascia. And they're just about the same caliber. And this is about 20 weeks post stem cell injection. Again, no surgery. This is the initial injury. And this is 20 weeks post, much more organized, looking fine. This is the dancer rehearsing at 20 weeks, and this is the dancer performing at 24 weeks. And really, that's why I do this work. It's a thrill for me to be able to get athletes back on the field of play. It's a thrill for me to keep an aging warrior away from having to have his knee or his shoulder or his hip joint replaced. That's what we do. I hope I have given you at least a passing understanding of what this is all about. I'm willing to stay as long as people have questions and would like to get some answers. Otherwise, please give us a call if you're interested and you have an issue. And certainly if you have imaging, gather that imaging and come on in with it. I'm happy to take a look and give you a professional opinion. There's a lot that we didn't cover here. The one thing that I want you to understand is that you pay me for an honest opinion. Is this treatment for everybody? No, it's not. I have another lecture on, who's a good candidate, who's not a good candidate. So I know what those parameters are. And I will give you an honest assessment. I have no interest in doing this on people that I have an understanding that it won't work very well for. I'll be very honest about that. Why? Because I've dedicated the past decade and more of my medical career to furthering this field. So I have no interest. Now I have to make a living, yes, but I have no interest in doing this on people that we know it's not going to work for. And this happens in my office monthly. I get at least one patient coming through the door with a horribly destroyed arthritic hip or horribly destroyed arthritic shoulder or knee. And I tell them point blank, after an exam and looking at their films, no, you need to have this joint replaced. I would be, stealing money from you if I agree to do a stem cell procedure here. Now, having said that, I have had people say, I don't care, doc, I want to try it. And I have, for almost every joint in the body, at least one example of an exception to the rule. But these are exceptions to the rule. These are people who shouldn't have didn't have better than a 30% chance of success, which is a terrible chance of success. It means 30% chance means that every 10 times I try this, 7 times I'm going to fail. Those aren't good odds. You don't want those odds. But I have told people that those were their odds, and they said, well, I don't care. I want to do stem cells anyway. And I have had some successes, and they're the odd case, because 7 times I fail in these patients. In other words, we don't get much of anything. We don't get what we want. We fail. We don't get the person happy back on the golf course, walking 18, that kind of thing. So in the majority of cases, it's a good idea, get the joint replaced, and typically they'll be happier. But that's what you pay me for, is my honest opinion, and I'm happy to give it to you. And if you need surgery, I will refer you, because I know lots of surgeons. I'll refer you to the best surgeons that I know. Any questions? Anybody? It looks like we have a question from Richard. Are these interventions available for degenerative disc disease? 1.2 to 1.5 damage and stenosis. I have had 2 cervical surgeries with a fusion, having pain and stiffness for the past 6 months. I had a laminectomy 10 years ago, and epidural injection is this year. My lumbar pain is chronic. I am 74 years old, but still very active, cycling in the gym. Richard, the answer to that is yes. Yes. We treat degenerative discs all the time. I treat stenosis all the time. There are varying degrees of severity. I'm happy to evaluate you with your film and give you an honest opinion of what I think I can do for you. But yes, this is something that we treat a lot. And because I was trained in spine and sports medicine at HSS, we inject the spine quite frequently in my office. Cynthia had a question. Why does insurance not cover? Is there sufficient evidence? Yeah, that's a loaded question, Cynthia. There's abundance of evidence now, but we've only been doing this in humans since 2005. So that's really the blink of an eye in medicine. And medicine is a very, very, very conservative field. it's a long, answer to the question of why insurances aren't covering this. But I fully believe that they will, and they will. Why do I say that? Because what I know as a doctor about insurances, they're all about money. They're all about money. And when they discover that a $6,000 to $8,000 stem cell procedure can solve an arthritic knee problem without having to go on to a $30,000 to $50,000 knee replacement, they're going to say, sign me up. You got to see Dr. Southern. Now, in the global scheme of things, not to blow my horn, but there are not enough of doctors like me who do this, who have the skill to do this. We have to train several generations of orthopedic surgeons in these techniques. And right now, they're not being trained in these techniques. Now, they're beginning to start doing this primarily because they're tired of hearing patients walk in the door and say, hey, doc, instead of the surgery, how about PRP? And a lot of orthopedics are beginning to do this, but they do it in a very cynical fashion. They don't understand it. They send their MA to a weekend course to learn how to do this, to draw blood and put it into a kit and spin it in a centrifuge and then do a single injection into a knee joint and say, there, you've had a PRP injection. That's not the way this works. That's not the way this works. At this point, we don't have enough people. We've had Blue Cross Blue Shield come and look at this kind of work and say, well, this is very interesting. Do you have enough doctors to handle our clientele? And the answer to that is no, no, we don't. If we had all the patients who were covered by Blue Cross Blue Shield walking into offices like mine, be inundated, be inundated. And it's not like I can just go down around the corner and hire another doc. Doc has to be trained in these techniques. So yeah, that's kind of a long-winded answer, but the answer can go on and on, Cynthia, as to why insurances at this point still don't cover this. Now, some do. Workers' compensation, they're highly motivated insurer, and they pay me to get their workers back to work. Yeah, they do. But because they have seen that orthopedic surgery is extremely expensive and quite frequently does not get people back to work. So they're much more willing to pay me a much, much smaller fee to do this type of work. And quite frequently, we're getting patients back to work. Happy workers. More questions. Robert had a question. I'm 77 and have bone on bone in both knees. I've been told by orthopedic doctors my stem cells are too old to accept stem cell therapy. I love that. Yeah, when we started doing this work, we thought that you could be too old for this, but have discovered that since that's not the case, because our harvest techniques are excellent. We don't need a ton. And if you place them precisely, you can get just as good a result, almost as good a result as you can get in a 20-year-old athlete. So that's simply not true. That's simply not true. And the orthopedic is basically telling you what they're not telling you is the fact they have no idea how to do stem cells. They have no idea. So they don't know what they're talking about. And this is also the pitch from fraudsters. Because this is still a cash in the barrel head world of procedures, there's lots of people doing this, including chiropractors who have no training whatsoever, have no idea how to do this. And that's what they tell people. Oh, your stem cells are no good. We have to use embryonic stem cells. Well, that's a whole other discussion. First of all, that's illegal in this country. It's against the federal code of regulations, number one. Number two, it's extremely dangerous. If you inject somebody else's cells into you, that's dangerous. And it's a felony. That's the third thing. It's a federal crime. So it can't be done. So anybody telling you that they're going to inject embryonic stem cells is basically telling you that they're going to get some growth factors out of the back door of an OB/GYN clinic. They're going to pay, a fee to get this little thing. And then they're going to hire a nurse because they can't even inject it legally to come in and inject it into you. And they're going to call it a stem cell procedure. Well, we've looked at this stuff. There's not a single thing alive in this vial. It does have some growth factors because it comes from placental tissue, but it's been irradiated to kill anything that's alive in it because that's what makes it safe to inject into you. If there was a living cell in there, you could have an anaphylactic shock reaction and die. So there's no stem cells in it, but it's being sold to you as stem cells. It's fraud, basically, is what it is. And orthopedics don't have any understanding of how you harvest stem cells from people, concentrate them, and put them precisely into areas of damage. So if you want an honest opinion about whether you're a candidate for stem cell therapy, please come see me. I'm happy to give you one. And the surgeon may be right. Yeah, I may concur and say, yeah, you're right. He's right. You should have that knee replaced. But I don't know until I see your films, and I can't answer that in a question and answer session like this. Any other questions? Ursula has a question. Can you harvest marrow from a patient with osteoporosis? Certainly. Yeah, osteoporosis has nothing to do with your stem cell. Osteoporosis has to do with the hardness of your bones, and it has nothing to do with stem cells. It has to do with your bones' calcium content. And that, especially in women, is set very early in life. And that's the problem with osteoporosis in women who get older. If you haven't received there's not enough calcium in your young years, and then you haven't exercised for decades and decades, yeah, you can have really bad osteoporosis. But that doesn't affect your stem cells. That's a totally different issue. So yeah, no, yeah, we harvest bone marrow from people who have osteoporosis all the time. It makes my job very easy because getting through osteoporotic bone is so easy. I have to be, quite careful. I have to go very, very carefully because the force I have to use to get into, say, a 20-year-old athlete's bone marrow, oh, I have to pull out a drill sometimes. That bone is so hard. But in somebody who is older, softer bones, osteoporosis, it makes my job easy. It's easy to get into the bone marrow. Now, I know this sounds awful, and this is a question I'm always asked. Isn't it terribly painful to get bone marrow? No, it is not. It is not painful if you know how to do it. Now, there are horror stories out there, and usually that's because the bone marrow that the patient who tells that horror story has had bone marrow drawn by a doctor who is usually a cancer doctor who's trying to get a sample of bone marrow to, evaluate for cancer. And they aren't necessarily trained in the proper way to do this to make it painless. Well, I am. So getting the bone marrow is not a painful process. I know it frightens the heck out of my patients, but they all say afterwards, oh, gee, that was nothing like I thought it was going to be. It isn't. That's because we take the first 15 minutes of a bone marrow procedure to just numb you up. And that includes numbing the skin, numbing the deeper subcutaneous tissues, and then, most importantly, numbing the cortical bone. If you do all of that, then I can drill into the bone and you don't feel anything, a little bit of pressure. It's not painful. I hope that answers your question, Ursula. Any more questions? Robert had another question. Thank you. Oh, well, no question. Thank you, Robert. Thanks for attending. Anybody else? Any other questions? I'm happy to answer anybody's questions, and there's no dumb questions. Anything that occurs to you. Richard, heard from Cynthia, heard from Robert and Ursula. All right, folks. I'm not seeing any more questions. Unless somebody raises their hand pretty quick here. Again, thank you so much for attending, and thank you for your time. And I hope that I have explained a little bit of this field to you. And I'm happy to talk further. Just give us a call, come on in, and happy to talk. We do a lot of talking in my office because we have to. This is a new field of medicine. And there's a lot of explaining to do. And for those of you interested in the literature, just, shoot me an email. I'm happy to send you the literature, some of the literature, if you're familiar with reading the literature. Most civilians are not, but we've got good literature. This is not just Dr. Southern's opinion. There's a lot of evidence out there that says this works, and in many cases works better than surgery. And certainly it's a fraction of the risk of surgery. Looks like we have one more question here. Let's see, Robert again. How long does it take for you to evaluate? How long does it take for me to evaluate? If you walk in the door with an MRI, Robert, that is within a year of, the index joint, I can give you an opinion in about 30 minutes. Another question. Neela, where is your practice? Good question, Neela. Yeah, my practice is in Norwalk, Connecticut. Interventional Orthopedics CT, IOCT. IOCT.info. That's how you can find me. But I'm in Connecticut. We're an hour outside of New York City, along the coast of Connecticut. Another question. Robert again, is a disc necessary to discuss? I'm not sure what you're asking there, Robert. I will say that some of the home runs that I continue to hit include chronic back pain with chronic discogenic pain. We go into those discs with bone marrow and we get some pretty eye-opening results. Yeah, it's one of the joys of doing spine work. So if you truly have discogenic pain and you know that, yeah, this is something that we can treat. Now, there are parameters for this. Like I said earlier, not everybody's a candidate. If you come in with a completely flattened disc, I'm going to tell you, no, no, I can't go into that disc. We're not going to get at all what we want. So there are parameters. You have to have 50% of disc height left. Discs that are torn with annular tears, these are the sweet spot. This is where we do really, really well. But it all depends on what I'm seeing on your MRI and what you tell me. So again, happy to give you an honest opinion. But we treat discs all the time. Yes. I hope that answers your question. What do I bring for you to evaluate in that half hour? Is X-ray enough? No, no, X-ray is not enough. But come in with your X-ray and we'll take it as a starting point. How my practice works, folks, is this. We have a hybrid model. We take cash only for the procedures we do. But if you come in, I will use your insurance. I will accept your insurance for that evaluation. If I take an X-ray, I will charge your insurance for the X-ray. Depending on whatever your deductible is, you will get reimbursed for that cost. If I need an MRI, I will order the MRI and we will get it ordered under your insurance and your insurance will pay for that. It's only when I am proposing a PRP or a stem cell procedure that there will be cost out of your pocket involved. And that only occurs after I have sent you a proposal, which you review in the privacy of your own home, and then call us with any further questions you have before we proceed. There's no arm twisting. There's no point of sale pressure in my office. Okay. That's how this works. So if you have just an X-ray, or even if you don't have an X-ray, come into my office. I have real-time X-ray. I can take an X-ray just by walking you down the hall and take a look. And that's usually where we start. And I usually have to get an X-ray before I can ask your insurance to get an MRI. First thing they'll ask me is, Dr. Sutherland, did you get an X-ray? And I'll say, yes, I did. As a matter of fact, and it's in my note, what I saw. Now I need an MRI. Thank you very much. And depending on what your deductible is, your insurance is going to pay for that MRI. All right. That's how that works. So yeah, really, you just need to come in. If you've got an X-ray, fine, bring it. If you've got an MRI, even better, take a look, bring it in and or arrange for me to look at your patient portal. Give me the password and username and I'll look at it in front of you and I'll tell you what I think. That's how that works. Any further questions? Robert, by the way, yeah, we carve out an hour for new patients. So you get typically an hour of my time, particularly if it's a complicated case and I need to discuss things with you and explain procedures, et cetera, et cetera. So this is very unlike an orthopedic office. I mean, I used to be in those offices where you saw 45 patients in a day. It was exhausting. You couldn't afford to spend more than 5 to 8, 10 minutes at most with a patient. You had to move on. That's not the way my practice works anymore. So come on in, bring your X-ray. I'm happy to look at it and give you an opinion. Anybody else? Any other questions? Again, really appreciate your time, folks. Thanks for coming out. Anything occurs to you, call the office, make an appointment, shoot me an email. I do answer emails. Thanks again, everybody. And again, thank you for your time. Good night.